No, it was a nice day, blue skies, warm weather, spring, so you kind of had the jitterbugs to get out and do something nice. Being on a motorcycle was very different. Kind of freeing. You were out in open air. Joyride, that's what I was doing that day.
Nick is a roommate of mine. I had pulled into my house, and literally when I pulled in, Nick must have been leaving. The other vehicle didn't see him coming over the crest of the hill. They pulled out in front of him.
You don't really have time to think. You lay the bike down or you hit the car, but you almost didn't have time to lay the bike down, so your only option was to hit the car.
Mutual 911, what is the address of your emergency?
There was just an accident with a motorcycle and a car at the corner of Cartwell and Broad Street. An ambulance needs to come fast.
I turned my volunteer radio on, and I heard a lot of the commotion on the radio.
Attention companies 2 and 3 fire and rescue. Motor vehicle accident, car versus motorcycle.
It's usually you automatically assume the worst.
Ambulance 20 is en route.
There was a pretty significant distance from where the accident was to where he had come to rest. So there was a lot of forces in effect. I recognized his tattoo before I actually recognized him, and he looked at me and he just went, "Hey." Just looking at him, you could tell his color, everything, he was bad off, and he knew it too. He was asked what his number one complaint was, and he said his hips hurt.
His blood pressure was just tanking.
Heart rate was through the roof. It was classic signs of shock.
Patient is awake, skin is pale, clammy, some movement to his hand.
Go ahead and get that flight in the air.
We don't carry blood on the ambulances, and that's really what he needed the most, that and surgery to stop the bleeding.
9-minute ETA for mid-flight.
We got him on the backboard, got him loaded. We started an IV on him and began giving him some fluids, and just knew that we had to get him to the helicopter. Nick's also a firefighter paramedic. He was demanding vital signs, definitely wanted to know what was going on.
We stabilized, they had an IV started, the EMS crew on scene did a fantastic job getting everything going. We kept the fluids running, we kept them awake, gave them oxygen, and we ran to the hospital. By the time we lifted off and gave our report, we were landing again.
He wasn't answering questions appropriately. You could look at him and tell that he was very sick, very hypotensive, had lost a significant amount of blood.
So the first thing we do in a hypotensive patient is look for where the blood loss could be. In his case, it could either be in the belly, the chest, or in the pelvis.
If I don't know the number, I just click it off. For some reason, I answered it. And it was a nurse. She said, "Are you aware your son's been flown into MCV?" I said, "No, ma'am, but you're going to start talking now."
We needed to get another IV in him right away. That was my job when he came in as a medic, was to draw his labs and to get his second IV in him if we could at that time.
Within 5 minutes of Max's phone call, I got a call from one of his friends that the accident had happened.
Well, motorcycle and car, you envision everything. It was tough.
We dropped everything and took off.
Based on our exam, you could feel that his pelvic bones were not quite in the position where they need to be. We got the x-ray of his pelvis, which showed literally a widening of the pelvic bones. You expect them to make closed circles. In his case, the pelvic bones were spread apart, and there's a lot of potential for bleeding and shearing of blood vessels in that area. And what we needed to do was close that space to try and tamp a knot or stop the bleeding. So we placed the binder and we repeated the x-ray of the pelvis, which showed that we were able to indeed compress the space. Resuscitated him with our massive transfusion blood protocol, and what that means is that immediately a ton of blood and blood products are brought to the trauma bay. Once that was done, we took him directly to the operating room, which was the safest place for him to be.
Our heart skipped a beat because the chaplain came and pulled us together. It was serious. It was serious.
We worried that regardless of which pathway we went down, he may not do well because of all the bleeding. So what we elected to do was keep the binder in place. In the operating room, we performed something called a damage control laparotomy. Our goal was to stop the bleeding, do the minimal amount we could to control all of his injuries, and then come back later to definitively take care of other things which could wait. While we were in the operating room, we had the interventional radiologist set up so that we could seamlessly take Nick from the operating room to the interventional radiology suite.
The trauma team are the quarterbacks in this scenario. By and large, if they decide they need us, they call us and we come running, more or less, drop what we're doing and we open up a room. Our approach is typically accessing an artery near the pelvis, and that was not available in Nick's case because the binder was there and we couldn't even loosen it for a little bit without his blood pressure tanking. So we had to come from an arm artery to move down through the chest, through the belly, and down to the pelvis to work. And here's an example where the contrast is clearly leaking outside of the confines of the artery. But scarier to me on the right is where an artery just cuts off abruptly. That's a clearly abnormal damaged vessel. Once the abnormalities are found, the usual treatment in a scenario like this is using a clotting agent that we can inject through the catheters into the arteries, and that'll clot things off and allow the healing to begin.
The most important thing for Nick's care in those 24 hours was to stop bleeding. The first surgical intervention, as well as the interventional radiology intervention, making sure that he got all the blood and blood products that he needed, and making sure that we ensured perfusion on the first 24 hours were key to his survival. Those are things that need to be done in an intensive care unit with clear communication with the team of nurses, interventional radiologists, surgeons, critical care, intensivists, doctors, everybody on the same page.
So this is a 27-year-old male who was on a motorcycle. He was hit by a car.
Nick is a young, healthy guy, so you'd give him, you'd resuscitate him with some blood product or some fluids, and he'd come up and he'd look good, and everyone would go, okay, good, we're moving in the right direction. But then, his bleeding continued, and then, an hour later, we'd come back in the same position, so.
We put on a special dressing called an Abthera device, and what this does, it's a big sponge. It's a window to the abdomen, so it means that we can see any fluid. If he continues to bleed, the fluid comes out into a suction device, and we can see that it's blood so that we can adjust it immediately and go back.
Initially, the pelvic injury, the bladder rupture, he was bleeding from all of those great vessels. So he had a tremendous blunt trauma force with the impact.
Nick was managed by our orthopedic trauma team, and he had a bad pelvic fracture and abdominal injuries. The whole pelvis was shifted out and up, the fracture. We put an external fixator and temporarily closed the pelvis, which was detached from the spine.
The orthopedic surgeons are focusing on his pelvic fractures. The nephrologists were focusing on his kidney function. So our job is to take into consideration all of their recommendations and all of their kind of efforts and create one conjoined effort to treat a patient.
Yeah, he was certainly critical. But I think when we, in my mind, he got through the first night, and it was an improvement.
In the first week, we had him as fixed as we thought he was going to get. We were going to transfer him out.
And then
everything went to hell after that.
Yeah, and the very next day, he turned jaundice, and it just became a cascade of bad complications, one after another.
They did say it was going to be a roller coaster. He's going to improve one day, he's going to go down one day. And we just didn't imagine what was going to happen.
One by one, kidneys went down, kidneys were affected, and then the liver joined in. So there was your jaundice.
He was real sick at that point.
Yeah,
his bilirubin had climbed to such levels that he was delirious.
Normal bilirubin is about less than 2. His bilirubin was up to the 20s, and we could not figure out why. We had the gastroenterologist involved, we had the hepatologist involved, we have interventional radiology, we drained his gallbladder, we optimized the blood supply that got to the liver, we imaged the liver to see if it was a laceration or if it was dying, and that's important because that has an impact in the rest of his organs.
Once you fix the big problem, there's always sequelae, and he was so sick at the beginning that when you have that degree of critical illness, something's going to happen. It's just a question of where and when.
Going into liver failure could have been an issue with him deciding between life and death. That was a life-threatening event.
We are imaging, we are looking at so many different labs, we're supporting him in every way we can, and finally it was just like, let's put the lights on him.
The next thing we know, they have Billy lights in his room, just like an infant with jaundice. Whether it did any good,
it helped you a lot.
But it's just our mindset. They are doing everything they can do.
That was actually the first time I had ever seen a Billy light used in an adult patient. There was concern that he wasn't perfusing his bowel well. He had profound abdominal pain at one point in time, concerning for infection, concerning for bowel perforation, and went emergently to the operating room to explore the bowel.
Devastating diagnosis of his bowels basically going to slough, and you don't know if it's going to survive. And they told his parents. Nick was very sick at that time, and he was sedated. He did not have any clue what was happening.
It was one of those normal days. He wasn't having a good day, but we didn't see this one coming. I mean, it was a bedside vigil, that night.
Everybody was very upset and crying, and reasonably so. And I remember seeing his dad leaning over him and saying, "Nick, son, for once, won't you just do what your mama says?"
Can't he get a break? He needs a break.
Dr. Albertanis said he's not playing by the rule books. This is not the usual course.
We look at labs together, we look at x-rays together, and we had hard conversations sometimes. Multiple times we discussed the possibility of him not surviving.
His parents were always at the bedside. One of them was
Yeah.
always there.
They
were
amazing.
writing things down and calm, but just wanting answers and wanting to know what we could do.
All you could do is rely on your colleagues and everybody's expertise and that constant vigilance of this is a small change. We need to address this before it becomes a big problem.
I'm a people watcher. If people are calm, I know they know what's going on. If they get on edge, I know we got a problem. And I'm sure they were very concerned, but they had that air of, we will get this straight. Well, that helped me more than anything.
It was an ongoing matter for everybody. It was a collaboration across the board just to make sure that we were not missing anything.
We went through a lot of GI bleeds. We went through a lot of, will he be able to hold nutrition? Are we going to end up with an obstruction given that he has a frozen belly at this point? All of that stuff.
He went for almost a week of absolutely no food. No tube feedings, no TPN, no nothing. His body was, again, kind of deteriorating.
Things on a daily basis would change and, just monitoring things really closely and making adjustments. But they were all things that we discussed on a daily basis and worked really close with pharmacy and the rest of the team.
And then, got him back to where he was a little back on track again. And then when the infection set in, he got really, really sick again from that.
Everything has an alarm, and every alarm means something. And you just know what your parameters are and your ideal goals, and you just work it. Once we got over everything inside, so, the liver, the gut, and everything in the kidneys are starting to come back to life, you're breathing better, he still had this metal bar in his pelvis, and our dear Dr. Munasami tried for 2 weeks, knowing that he was going to be leaving the ICU soon. You know, we're going to internalize that hardware. We're going to get that thing hopefully fixed. And every time he tried to take him to the OR, it was an unacceptable situation to try to do that.
The primary concern is him as a whole person. The only way to save him as a whole person is to first temporarily stabilize him and wait for other problems to settle down.
Dr. Munasami was every week we would laugh and say, all right, next Monday he's going to have surgery. Next Monday he's going to have surgery, and it never happened.
We couldn't fix it with plates and screws. It was a big delay in getting him rehabbed and mobilizing him.
I remember the day when he was sent to rehab, and it was like a bittersweet moment because we were so happy that he was doing so much better. But it's now it was like, oh, like we care so much about you and we're gonna miss you.
Almost twice. He's so motivated to get better.
Good.
He really works hard, and therefore it shows.
Ready to get back to work. Tired of being a patient.
He was dealing with the physical limitations even though he was healing inside. So there was no choice for him. He was like, I'm moving on.
The last time we encountered Nick in the unit, the tracheostomy tube had been removed. He was smiling again. He was able to eat real food.
So he actually went home with that X-Fix on his pelvis. Went to rehab with it on. He went home with it on.
All right, Nick.
Red, huh? All right.
Get it behind you.
Dr. Munasami, he was a smart man. He played it right. You know, after they took the external fixator off, everything is healed. He did not have to do any additional surgery.
All right. Well, let's just keep the settings as they are. I really want you to push yourself.
What I really see that my role is kind of grading the challenges that we present to him. You know, our long-term goal is for him to be up and walking and not needing a cane.
All right. Can you sit for a minute, or are you good?
I'm okay.
The part that's been so thrilling and exciting to work with him is, you know, he'll say, yeah, you know, I was sore going home, but I woke up and everything was okay. So that's, you know, for me, big green light.
I truly believe that there are some patients who, no matter what happens to them, they will survive, and Nick is a survivor.
It was not the typical trauma patient. We were always in our toes. I learned tons from taking care of Nick.
I've in fact worked in many trauma centers around the world. I don't think a person with such injuries could be brought back to what level he is today in many centers.
Knowing that he was in the best place he could be. Of all places, he got flown into Richmond. We were good.
It makes me so happy to see it when, you know, the parents are so deeply involved in their child's care, and he had the biggest team rooting for him.
From the lady that came in and cleaned the rooms, you know, all the way to the top brass. We treated them like family, and they treated us like family.
That guy had the best attitude. He was so fun to walk into. First of all, he has a pearly white smile, as everybody is going to see.
Yes, he does.
And he's got a great sense of humor, but he was always positive.
He'll be a big model to other patients, how they should have determination to come back.
He's got guts.
Yeah, he's got working guts.
I can fix anything. I couldn't fix that. I'd have traded places in a second. That's the first thing I told them, but I couldn't do it. They did it for me. Oh, we had a good day. Made my life good again. I like that.